him take control.
All right. Well, Lynn, if you were listening last night, a lot of this is going to be the same, but I'm going to go really quickly through this and then just let's talk and have questions. I don't want this to be terribly formal. As we already mentioned, on March 2, the Board of Health offered my job to a new executive director. They thought about it and then said it was not a good time for them to move. I don't know why they applied in the first place. So anyway, on March 5th, we had our first COVID case in Colorado. It was a case in Summit County, and they moved it down to Jefferson County to get it at a lower altitude. So theoretically, we shared the first COVID case in the state. And because of the COVID outbreak and because of financial problems that the Jefferson County Health Department is looking at, and because of a number of reasons, I told my Board of Health I would stay on at least until we had some stability, so I am still here. Next slide, please. You both know about public health. It is a branch of medicine, but it's a branch that most people don't know a whole lot about because we really don't see patients so much, we see populations. So we work with populations in workplaces and in jurisdictions like counties and states, and we focus on what's going through the population. You probably also know the difference between an epidemic and a pandemic. This epidemic started in China and was sort of centralized in the Wuhan area of China and central China, but then began to move out into other countries, first into Asian countries like Singapore and South Korea and Japan, Taiwan, Vietnam, but then began to move because we have such a global network of travel these days, that it was very soon in Italy and Spain, and now it is all around the world. Epidemic just means it is higher than what you normally would expect in a disease. So if you have one case of smallpox, that's an epidemic. It's not by number, it's by expectation. Pandemic means it's gone around the world, or it's in numerous countries. It was interesting, the World Health Organization took a long time before they declared it was a pandemic. I think that was for two political reasons. They didn't want to make the Chinese mad, and also they didn't want to make President Trump mad, because China and the United States are the two biggest funders of the World Health Organization, and they were a bit concerned that they would anger their biggest funders. So the questions then we had as we watched this new virus was, what is different about it? What do we know about it? They actually were very quick in figuring out its genome and getting its genomic structure out to the world, so that very quickly people began to do studies on it, began to make tests for it. In the United States, we decided we were going to use our own test instead of using the one the rest of the world was using. That led to problems that we'll talk about a little bit later. What the issue in public health is, for 20 years, we've been saying there is going to be a pandemic. We thought it would probably be a influenza virus that had shifted, that had been reorganized in probably a bird or a pig, and would then become a pandemic. The concern we had, and this is really the thing that keeps public health people awake at night, is how quick will it move through the population? Will it be transmitted from person to person, and will it be quick? And then how severe will it be? How deadly will it be? And our concern was that we eventually would have a new novel virus that was transmitted rapidly from human to human and had very high mortality rates. So when H1N1 came out, or H5N1 came out, we were very concerned. Fortunately, those did not travel quickly between humans and did not have high death rates. But when this came out, it was obvious that it was traveling very quickly. And in China and in some of the European countries was having fairly high death rates, much more than the flu, which we'll talk about a little bit later. So the question then was, do we know enough about it that we can make a vaccine? Do we have any vaccines that might be good for it? Do we have any medications that would treat it? And all of those came out as negative. They tried some of the new antivirals. They did not work. they began using all sorts of off-label medications such as hydroxychloroquine and ivermectin and azithromycin, and found that none of those were working. We also had no vaccines that were working against this novel virus. And so we really lost years of technology and had to go back to the late 1800s, early 1900s of how do we control epidemics? Well, we make people stay at home. We isolate those who are ill. We quarantine those who have been in contact. We use a lot of hygiene to keep people from passing this. And that's really what we've had to do. The difference between this and the flu is that this has a much higher hospitalization rate and a much higher death rate, about 10 to 20 times higher than the flu. So when it first started coming out, there was a lot of political talk about this is just the flu, we don't have to worry about it, and we can quickly have a vaccine for it. Those all turned out to be wrong, and it is much more serious than what we originally, or some people originally thought. We've also learned a lot about its spread. Originally, we said if you stay 3 feet away from everybody, that'll be fine. It's droplet spread. We then learned that droplets actually move a bit further than that. So we've been telling everybody to stay 6 feet from each other. That's the social distancing. Now there are studies that have showed that it can be aerosolized and that even with a violent sneeze, it can move 20 to 25 feet. So particularly if you are running or biking and you are drafting on somebody, you should stay at least 25 feet behind them because their breath can move that far and can impact you. Of course, if you're 25 feet away from them, you're not drafting very well either. But so we began to look at what are the political things we need to do. We decided that we needed to put a stay-at-home order in place. We worked very hard to do that in the Denver metro region. All of the 7 health departments got together and said, let's do this together. Then the governor came and said he was going to put a stay-at-home order in place 2 hours before ours was scheduled to go into being. So we decided to go with the governor's, and we backed off of our stay-at-home order. Denver went out on their own and had a little bit difference, found out they had some problems, and theoretically have come back so that all of the Denver metro region now is in line with the governor's stay-at-home order. But all of these changes, when you put out different rules and regulations or different orders, it's very confusing to the public and it's very maddening to the public. The public doesn't particularly like public health anyway, because we do things like regulation and orders, and in the West here particularly, we don't like government telling us what to do. But then when we don't have our facts straight, we keep telling them new things about the virus or new things about the restrictions. It really does make people angry. As you have seen here in Michigan yesterday, they had a huge rally calling for the governor to be thrown in jail and all sorts of things. But one of the problems is science is ambiguous. Science is a process that does not lead to certainty very often. So most people who do not know much about science are very frustrated with what we're doing, but we are trying to base everything we do on science. Other hygienic principles that we tried to stress were make sure you're washing your hands, keep your hands clean, either wash them or use sanitizer. When you sneeze, don't cough or sneeze into your hands. Do it into the crook of your elbow. Keep the hands away from your faces, mainly because the area where this spreads the most is in mucosal membranes, such as the linings of the eyes, the nose, and the mouth. So those were at least simple things we could tell people to do. And even my 4-year-old granddaughter now knows how to wash her hands for 20 seconds. I already mentioned these. I'm sure all of you recognize that this is hydroxychloroquine and azithromycin and ivermectin from your biochemistry and organic chemistry days. But what we have found, and just actually yesterday, an article came out that one of the studies that was being done on hydroxychloroquine, which for some reason our president has really fallen in love with it, They stopped a double-blind trial of it because they were having so much heart disease in those who were taking it. So it is not a benign drug, and it also can cause problems, GI problems to some people. And actually, there are some neurological problems that chloroquine and hydroxychloroquine can cause. So at this time, we do not have a medication. The best treatment that we have is symptomatic treatment. And so we have, we try to take care of their cough, we try to take care of their fever, we try to make sure they're getting oxygen with ventilators. And that really is the best treatment that we have at the current time. There is no cure for this at the current time. Two of the biggest frustrations that we have had through this, the first one was the testing, and I mentioned a little bit about that. But the second one is the availability of personal protective equipment. We had stored some caches of protective equipment after the H1N1 and H5N1 concerns. There is a strategic national stockpile, which also has sent now 3 shipments down to us. But we continue to get requests both from the 2 hospitals in Jefferson County, as well as all of the congregate care homes, the home health agencies, and individuals who are looking for personal protective equipment, as well as emergency medical system, first responders, and law enforcement. And we just don't have it. So it's a huge frustration. The second one is the testing. The testing has been a real problem in this country. It began with the CDC saying they were going to do their own test. I'm sorry, I'm jumping around here for you. Sorry, Stephen. They did put together a test. They sent it out and then found that the reagent did not work, so they had to recall it. They then said all of the tests needed to be sent to the CDC to be run. This was a very slow process. It was taking 7 to 8 days to get reports back, and then if there was a positive, it had to be sent back again to be confirmed. They then sent out the testing ability to the state laboratories, state public health laboratories, which sped it up a little bit. But state public health laboratories are not tied into the medical systems like hospital laboratories are. And so again, there was a huge sort of a bureaucratic slowness of getting the results out, getting the results to the people to whom they needed, getting it to the doctors who were ordering them. Eventually, they did open it up so that more of the hospital laboratories now have the ability to do the tests. Also, Quest and LabCorp and other private labs are able to do the test. And so it should be good. The problem now is we don't have enough of the testing material. The reagent is still hard to get. The swabs are hard to get. And so it is continuing to be a major problem. Because of that problem, the FDA opened up what's called their Emergency Utilization Act and allowed a number of organizations and companies to start making tests without having to go through the strict testing that FDA does before they allow these things to get on the market. So we have now 20 to 25 different kinds of tests. We have a number of the molecular tests that look for the virus itself. We have a number of the serological tests, which look for IgG and IgM in patients who have had the disease. But there are very few that have actually gotten the FDA final approval. And so all of the other ones are very suspect. At least I suspect that they do not have the credibility. I was listening to one of the people who was trying to sell one who could not say the word specificity. He kept saying specificity. And it was just obvious that he didn't know what he was talking about. And so again, we've lost a lot of credibility because of the lack of testing. And that reflects on all of us in public health. I don't know where we are on the slides now, Stephen, but this is a statewide dashboard that shows where the hot spots are. I think Stephen said he took it this morning from the Douglas County website. Most counties now have a website that you can go on and find what is going on with COVID, at least in the county. Some of them do show the whole state. As you can see, it is mainly along the Front Range and in the resort communities in Colorado. Actually, the resort communities ended up having some of the first hotspots in Colorado. There was a big outbreak in Pitkin County because of some Australians that were here who ended up having COVID. And then now it's moved into the Front Range. So you can see how that has spread. I think for the most part, that is my presentation. Like I said, we're very informal. We're a very small group. So please, if there are any questions you have, I will try to answer them. There's a lot of stuff going on about stay-at-home orders and when are they going to be lifted, and we can talk about that, or anything that you might be interested in talking about, I'd be happy to try to address.
So I have a question for you, which is, they showed, I think Dr. Franz showed the California, what we would need to open up. Mm-hmm. And one of them is the ability to test and track. Do you have any sense of when we are going to have, so part of the testing, and it's been on the base camp discussion, is the ability to test reliably so if people can return to work. That's one thing. And the other, of course, is testing people so that you can, and tracking contacts, for which you need a much larger workforce than you have in the state in public health. So how do you see that being implemented since we don't have the equipment or the person power? Excuse me.
Yeah, the four things that we're really looking for, and there's some variations of these around the country, but most people agree that at least there's four critical items that we need to have in place. One of those is a reliable test so that we can actually test and find out, does this person have immunity? Are they safe to go back to work? That in itself is sort of a fallacious argument because we don't know how long the immunity lasts yet. There are some reports of people who have had it more than once already. Usually with the coronavirus like this and with SARS, there was some immunity for at least 12 to 18 months, but we don't know. So even if you have an IgG positive test, that means you've had it and you now have some immunity to it. We don't know how long that immunity is good. I still think it's probably going to end up being about a year to 18 months. And I think that even if it doesn't last completely, that it probably will decrease your symptoms the second time you're exposed to it. So that's one very important thing for getting people back to work. As you mentioned, it's also, it's vital for us to do surveillance to try to find out where are the hotspots continuing to be in the state. How can we zero in on those hotspots and the contacts that they have had so that we can do contact tracing and isolation and quarantining to stop that. So that's one of the big things that needs to be in place, is a reliable testing that is both reliable and enough of them to be able to do them in a population. We do not have that. The third thing that goes along with that is we need PPE for those who are doing the testing, and we do not have that. So the very first step in opening up the society, we do not have. The second step ties in with that, and I already mentioned it, and that is, are we able to trace contacts? And you may have seen there are some numbers saying that there should be about one person per every 1,000 people in your population. In Colorado, that would mean 5,000 public health workers, and we have nowhere near that amount. We're looking at trying to expand the education of some of the retired physicians and nurses that may help us with contact tracing. But in the larger counties, we now have about, like in Jefferson County, we have 30 people doing contact tracing, and we have 500,000 population. So just in Jefferson County, we ought to have about 500 according to the guidelines. So we do not have the ability to trace or to test. The third thing is, do we have the hospital capacity to treat those who are coming down with the disease? And it looks like in Colorado we do. We have had some spikes. We've had some places where there have been some shortages of particularly PPE, but also some shortages of ventilators in hospitals, but not across the state. So it does look like we probably do have the ability to treat once we do identify cases and when cases come in. The fourth one is a real kicker, and this is the one that I think is going to take the longest, maybe even longer than testing, although that's going to be a push. And that is, have we seen a decrease in the number of cases for 14 days? And 14 days is chosen because that's the average, or that's the incubation period. So have we seen a drop in cases for 14 days in the state instead of an increase? And we have not come near that yet. We've seen a decrease in the increase, meaning we're seeing less cases every day, but we have not yet started seeing a drop in the cases in Colorado. So at least 3 of the 4 are not in place for Colorado. That brings in the politics of public health, and I believe that there is going to be such a push eventually, before we even have those 4, that there will be such a push by the business community and people in general to open up the stay-at-home, that there will have to be some sort of compromise as we go forward, and that we will have to begin opening up the public slowly, trying to keep the social distancing as much as possible, trying to ramp up testing and tracing as much as possible, but that in a tiered approach, opening maybe some retail businesses where they can keep social distancing, or maybe do more curbside deliveries or home deliveries, those kinds of things, but at least get businesses back going. Second, moving more towards those places where people tend to congregate in restaurants and bars and things like that, begin to open those up, but still have social distancing, so that maybe half as many tables or less in restaurants, and separation areas. Talk about plexiglass separation between tables and things like that, booths and things like that, but trying to keep that social distancing as we open up that. And then third would be those larger congregation types of events, such as church services, baseball games, football games, concerts, special events. And, in the mountains, there's a lot of those in the summer. Those will probably be the last, because social distancing is going to be so hard to try to keep that up. So I do think that even without those 4 things in place, Lynn, we're going to have to start opening things up based on the political pressure we're going to get. The flip side of that, though, is that the workers are a little bit afraid of going back to work. And so there's not as much push by the workers in some places as there are by the business owners. And so the business owners are also going to have in place some kinds of things that are meeting the needs of their workers, such as possibly checking temperatures and symptoms on everybody as they come to work, getting rid of some of the cubicles and separating people a bit more, letting people who have offices work in their offices without masks, but most of the other people who are in the common places having to wear masks and do various things, which then raises the whole issue of inequity. If you have an office, you don't have to do certain things. If you're in a cubicle, you do, and there's going to be some pushback around that. So that was a very long answer to a very short question, Lynn.
No, so I'm curious about the mask. Certainly one of the things that's mentioned is that, and I've seen a couple of YouTube videos, which are basically saying everybody should be masked when they go out, which I don't have a problem with. I do have some questions, though, about how you go out to a restaurant and eat with a mask. But other than that, do you think that's going to be a recommendation?
I think it was going to be a recommendation that as much as you can when you're in public, wear a mask. I do not think it is based on very good science.
Yeah, that's what I wondered.
There are some studies that have shown that a cotton mask, like a t-shirt or a towel, does cut down the spread by about 50%. And then there are some other studies that say it's about 2%. So it, particularly if you're wearing it a long time and they happen to start getting wet. So it'll probably be one because it's something we can do. And in a situation like this, everybody wants to do something. But I'm not terribly convinced that it's a huge public health safety measure.
If it's not, for one, I'm going to not spend the next week making masks for people. But the other is, how do you protect workers going back to work, since we have no official PPE and it doesn't look like any is forthcoming?
That's the second reason we'll use masks, because they do something. But the biggest thing is social distancing. That really is the key. And some businesses are going to have a very difficult time keeping that, having social distancing, both with their workers and with the clients that come into their businesses. But at least I think through the summer, those are going to be the things we're pushing, is social distancing and wearing masks when you're in public.
Okay. And the vaccine is going to be ready tomorrow?
I think it's probably already ready, but we're just keeping it secret so we can make more money at it. You know how those pharmaceutical companies are. No.
Well, if I know anything, it's those public health physicians get those massive kickbacks. That's why they're all in their big mansions.
Those are supposed to be secret, Stephen.
Oops.
Oh,
This is being
I
recorded.
won't tell anybody.
I don't know. There are some vaccines that are being pushed rather quickly. There are some that actually were already being looked at, that they're trying to modify some of the chains in the antigens in to see if they can do it quicker. But I still think it's going to be 12 to 18 months, like Dr. Fauci has said all along, before we really have one that is reliable, that is safe, and that then the problem is manufacturing it enough to get it out so that you can vaccinate 300 million people.
Well, they did it with polio.
They did it with polio. They absolutely did. But that was a different time. There was a whole lot more trust in government and in public health. And they gave you sugar cubes.
Oh, well, that's just it. We just need to put it all in sugar. Every American eats 400 pounds of sugar a day. We could just put it in sugar.
Yeah. No, I think there will be one eventually. Again, how long that will last, whether we have to do yearly shots like we do with influenza, I don't know yet. Again, that depends to some degree on the immunity of the virus itself. So a lot of things that it's kind of interesting to me as a historian. I don't know if you know, I teach a history of public health class at the School of Public Health every year, or every other year now. But it is, on one side, we have detected the genomic pattern of this and have gotten information out, and have already had over 400 articles published on the virus. We know more about this virus quicker than we ever have in the history of the world, as far as I know. And then on the flip side, the only thing we can do are use modalities that came around at the beginning of the 1900s. It's just amazing how you have the dichotomy between the modern and the old having to work on this.
Just go far and go for a long time.
Yeah.
That's, what is that, 16th century or before?
For which?
Go far and, don't come back.
Oh yeah. That was in the 1600s. It was actually in the 1300s too, with Black Plague. 1300s was Black Plague. 1600 was plague again in London. But yeah, and it was physicians that left town, and it really hurt their reputation. People were very angry with them. They just abandoned the cities, as did all the rich people.
Right.
Which also spread the disease, but that's the flip side of it. So, well, I don't want to keep you all longer than you want to be here. If there are any other questions, I'm happy to address them. I appreciate
So are you staying safe yourself? Are you doing most of this remotely?
I am going to my office every day because that's the only place I can get work done. I have a 4-year-old granddaughter living here at our home. And so I go to my office, but when I get to the office, there are usually 3 or 4 of us, and we each have our own corner hundreds of yards away from each other. So yes, I am staying safe. The ironic part of that is my son-in-law is a respiratory therapist, and my wife is a on-the-floor nurse in labor and delivery.
Oh,
So whether I'm being safe or not, and we're all doing the best we can, but it amazes me that nobody's come down with it yet.
that is, respiratory therapy is actually the highest,
Yeah.
most dangerous job somebody can do these days.
He knows that, and he is very, very careful. He changes his clothes as soon as he comes home and washes them, and he doesn't touch things. And I mean, he's just very, very careful. But the problem is when you intubate somebody, you're getting all of that aerosol and all of that.
I
So
know. Well, take care of yourselves and your
thank
family.
you, Lynn. Thank you, Lynn. Thank you, Rachel, for tuning in. I hope it was
Thank you.
helpful.
It
Thank
was
you,
very
Steve,
helpful.
for lining it up.
Thanks,
Thank you,
Dr.
Stephen.
Thank you all. Appreciate your
Alright.
time.
Everybody stay safe.
I'll see you
Thank you.
all in a week
A week.
online.
Okay, all right.
A week.
Bye.
Steven,
Yes,
what's in a week online?
a board meeting.
Oh,
That
so I'm not going
Eventually, when you join the board, you'll be a part of, Dr. Saul.
I won't be attending that one. Okay.
Not yet. Not yet.
I was gonna say, hey, I didn't get the invite. What the heck?
Next.
Sure.
So actually, Rachel, before you get off, is the office, are you masking your patients?
Well, we're actually not doing inpatient office visits.
You're doing all telehealth?
It's mostly telehealth, but when folks do come in, we do give them a mask. Like
Okay.
if they had to come in for a vaccine or blood
Mhm.
work or something like that, yeah, they're wearing masks. But that's few and far between that are coming into the office on a daily basis. It's usually like less than 10, maybe something like that, maybe a little bit more. But yeah, most of our visits are telehealth,
Good,
like 95%,
Yeah.
great.
I'd say.
Good.
Maybe even
Stay
90%.
well, everybody.
All right.
Right.
Thank you.
Thanks,
Thank you so
everyone.
much.
Thank
Thank
you.
you.
Bye-bye.
Okay,
Bye.
bye-bye.